Good afternoon, and first I would like to invite Dr. Tamanas Chaudhury, and I think he does not require any introduction. He's very much from this city and very famous laparoscopic and general surgeon, and he will speak on laparoscopic splenectomy approaches and troubleshooting. Dr. Tamanas.
Thank you very much, sir. I know a lot of my friends who are not exactly doing GI surgery practice. A lot of general surgeons here who are facing a lot of trauma and other situations where they may require splenectomy, but definitely the laparoscopic splenectomy not for those, particularly for traumatized people with hemodynamic instability. The laparoscopic splenectomy is one of the surgery where we have to pick up the patient very properly. We cannot take a huge spleen of a thalassemia patient. We cannot do that. We cannot manipulate. We will not get enough space. But for technology, to understand the techniques how to do a splenectomy, I think that also help to do splenectomy in open surgery also. So I just run some videos. Please run. Laparoscopic splenectomy, before coming to doing the exact surgery, some of the anatomy. Run the video, please. Yeah. That we all know is one of the very highly vascular organ, and there is a lot of attachments, but in laparoscopic splenectomy, we must be very careful. We cannot detach the attachments and early part, which we can do it open surgery. But in laparoscopy, we have to do it vascular control first, then only we can remove the attachments because that's adhered the spleen. It's very difficult to manage the spleen. These are all standard indications which I am not detailing. We can have an anterior approach, lateral approach. The best what we do practice is a semi-lateral left side up. And one very important tips is if the spleen is bigger, we make less semi-lateral. Means the more the patient will be flatter. If the spleen is bigger, patient will be flatter. Otherwise, the moment we make this angle, basically the spleen will hang and the assistant will help for holding the spleen to visualize the vessels. So this is one of the, this is a slightly bigger spleen. I don't know, lights off please. Lights off. Yeah. So some of the attachments we just dissect, particularly in lower pole, we take some attachments for slight mobilization of the spleen, but our first target is to control the artery. Before going that, for slight mobilization, we take some attachments in lower pole. Then we are opening the gastrosplenic ligament and to open up the lesser sac, and we'll get all the short gastric vessels in this line, in same line, and we can see the pancreas just below it. So by left hand, the assistant job is to just hold the spleen in place, and assistant role is very, very important. He will not manipulate anything except at time when only give a support, only the support to the spleen. So till we go to the fundus, we take the all short gastrics, and if we can mobilize the short gastrics, this is the area where there is a possibility of, I'll show one video in this presentation where surgeon may injure the fundus of the stomach. This is one of the another bad complications may happen. So now our purpose will be take the spleen, take the splenic artery. The moment we can take the splenic artery, that gives a real good control. The volume of the spleen may come down. It can be easy to manipulate, and that's why. And we should not hesitate to dissect on this, holding the splenic artery, and to create a window behind it. And we must be very careful at this point. If any time we injure the artery or the splenic vein nearby, then there is a possibility of a huge hemorrhage. So we just clip it, we will not divide it. Because we divide the splenic artery at the pole only, we just here just put a clip. Hemolox, we can tie it over also with a Maryland forceps. We can put a silk knot around the artery. We are not dividing the artery. We are just now completing the other attachments, short gastrics, some of the short gastrics here. Now we are concentrating to the splenic vein, and these point we must be very careful not to injure the tail of the pancreas. There is a lot of options to control at the pole. There is other energy sources we can use it. This is one, we are 5 mm ligashore we are using. We can use the harmonic, we can use the ligashore, we can use the staplers. That I'll show that different kind of vessel managements we can do, but definitely our purpose not to injure the vein, even in this point. So just as minimum as tissue around, we should keep it, just gentle dissections. Till now, the assistant, and probably you have seen at the very early part, there was some bleeding. We stop it there with a piece of gauze. And if any point, if there is any injury to the spleen itself, it is very difficult to control. So we must take a utmost care not to injure the spleen at any energy source or any instrument, so that if any splenic injury, we cannot control that either by suturing or by any type of energy sources. So the first trick, not to injure spleen at any point till the vascular control, whole of his vascular control is with us. So now at this point, we can suture, we can put a ligashore, or we can put a hemolox. All options are there. We are almost create a window behind the vein, splenic vein, and sometimes we may require 2 to 3 branches. It may not to the very close to the spleen. If it branches 2, 3, then we have to put individually. But if it's a enough bigger diameter, we can put a hemolock clips, which is sufficient one. So after that, we are just we are taking the other attachments around the spleen, and if any spiniculi, we have to remove it along with the specimen, and for that purpose, we must dissect individually if required those spiniculi. So now we are taking all other linodenal ligament, everything we should take out, and this is the time we have to manipulate the spleen. So we request to roll out the spleen from top to bottom. Sometimes it's adhered with the diaphragm, so that also to be divided, all attachments around. So now we are pulling, we are just rolling the spleen to see whatever they were. This is the area where it is very difficult to reach. But now if required, we can slightly more, we can go for a semi-lateral positions. We can use the gravity as a retractions. So this is one situations where we can use the staplers. So this is the certain complications may happen where for short gastric, there is injury to the stomach, and this is one really bad complications. We must be very careful. It should be, sometimes it is very hardly any space between the spleen and stomach, but it's always safer side to take a very small amount of tissue, dissect it, then only we do it, otherwise we should not injure. And another situations where there is a possibility of pancreatic tail injury, particularly if somebody like to put a staplers around the vessels, there is a possibility is high, but until unless we dissect the splenic pancreatic tail properly, we should not take any sutures or any ligature or staplers around the vascular bundle. We have to take out the tail of the pancreas. Sometimes it can be almost like it embedded in the splenic pole. Thank you very much for your patient hearing. Thank you. Thank you, sir.
Thank you, Tamanas, very crisp video presentation of laparoscopic splenectomy. Because it's a troubleshooting, so I invite the question from the audience. If you have faced any technical problem during splenectomy, so you should raise your hand and ask the question. Please introduce yourself and then question.
Yeah.
Also the semilateral, as you said, so you actually let the left shoulder fall back. The other thing that I have done on occasions, I just want to sort of share with you and perhaps get your view on this. In some of the spleens, actually standing between the legs and doing it from the French position is also quite good. What do you think?
True. Yes. I just add one sentence. This is a very personal sentence. Dipankar and myself started together being MSPG at HPB. Now he is our international faculty of this conference. Welcome, Dipankar. Meeting after so many years.
Any other question? So I'll initiate other people are preparing the question. Suppose that there is an injury to the fundus of the stomach. So what are the various maneuver you will take to one, to avoid this, and secondly, if it has taken place, how will you handle the situation during the surgery?
Sir, first we must be very careful not to injure. For that reason, sometimes it happens the stomach is almost very close to the spleen. So gentle, small amount of tissue with the energy source if we proceed. Even if required, sometimes we have to use the cold knife so that there will be no injury to the spleen, no injury to the stomach. The first thing is to prevention. If at all happens, we can put either suturing, and definitely if it's due to some energy source, we have to refashion, then only we can put the sutures, and by PDA 20, it's good enough to suture that fundus part. Thank you, sir.
I'll add this, if there is a big enough hole into the fundus of stomach to the greater curvature, even the NDO-GI stapler, you can fire it, and it's very safe and easy rather than taking it. Yeah. Sir, Dr. Nandi, please.
Yes, sir.
Can you do it in portal hypertension? Say that you want to do splenectomy and devascularization in a person who does not have a shuntable vein, say with extrahepatic portal venous obstruction. Would you do a laparoscopic splenectomy?
No, sir. We have no
Is it
experience of
possible?
doing any splenectomy in portal hypertension. Sir, we have not done it. No, sir.
Because it's always stuck to the diaphragm
Yes, sir.
with big
Yes, sir.
collaterals. Have you done any?
No, sir, we have no experience of doing any splenectomy.
He
in
does not
portal
have any
hypertension.
experience in portal
Portal
hypertension.
hypertension, sir.
No experience
We have
in
not
portal
done it, sir.
hypertension.
You have not done it, sir.
Anybody in the audience have any personal experience of doing splenectomy by laparoscope in portal hypertension? With multiple, yeah, please.
Yeah, Senthil.
I think, we have a few cases of portal hypertension with splenectomy. It's the heart in the mouth status. We have to be all the time, we have to be very careful. Even the last bit of vessels have to be taken. Even after splenic vein and the splenic artery being divided, some of the pericollaterals, perisplenic collaterals can bleed like anything. We have used staplers, 2-3 staplers to tide over that crisis. Artery done, vein done. When we are dealing with perisplenic collaterals, our choice is to use staplers rather than dissecting individually the vessels. But again, sir, it's very tough, very difficult, very highly selected patients we have to take care, and keep that open table ready, compress it. I have converted in one patient after compressing. It's a control conversion, mechanical compression, and then convert it.
Thank you, sir.
Thank you, Dr. Sendil.
learning.
Dr. Tamanas, in large spleen, what are the various maneuvers do you use to remove the spleen without making a large hole?
So, normally we remove the spleen from a pharyngeal incision, and always we put a bag. Sometimes we may not put a bag, we cannot manipulate the spleen within the bag, so we just put a pharyngeal incision. Some of our, at least hand breath, we put the hands inside, we rotate and take the in-axis and pull out from the pharyngeal incision. Yes, sir.
So, any,
Good morning, sir. I'm Dr. Kush Parikh from SGPGI.
Yes.
So, in case of a large spleen, while performing a laparoscopic splenectomy, if you happen to injure the left-sided dome of the diaphragm, how would you manage it intraoperatively? Would the pneumoperitoneum be difficult to maintain, and then proceeding laparoscopically, would it create any problem or not?
Sure. Whenever we do any injury, I have not exactly any experience of doing diaphragm injury, but theoretically what we do, we should immediately we should ask warn the anesthetist that there is some injury, some left lung may collapse immediately. So we must be ready to put one at least intercostal drain on the left side. Then only we can repair it. And I think if we put a drain and if you can hold the two sides of the, and I think it's maybe it's not a huge defect or a huge injury that can be sutured laparoscopically. It can be done.
So, but intraoperatively, loss of pneumoperitoneum
Yeah,
would be an issue
that thorax also be within together. the means the lungs, means thoracic cavity and abdomen is together. So we inflate, and thorax normally does not inflate, only the abdomen. So we just keep on going in, repairing, and definitely before repairing, we should put an intercostal drain before we start the repairing the diaphragm.
So I will let to, there's a lots of consequences of kind of the air leaking with the peritoneum into the thoracic cavity, and this leads to lots of change in the hemodynamics of the patient. And sometimes you may find the hypercarbia and even the bradycardia because of the absorption and leaking from this. And obviously the most technical problem is to maintain the pneumoperitoneum, but it can be done if quickly, if you can do it. So any other questions from the floor?
If I could just respond to what you said about that. We have a similar situation when you do a very giant hiatal hernia, you do a diaphragmatic release. You actually induce a carbothorax by doing that, and it is not a problem at all. All you have to do, the patient is on intermittent positive pressure ventilation, the lung is going to expand, and you just stitch it laparoscopically. It's not a problem. In fact, I have not used intercostal drain in that situation. All you have to do is to just inflate, and then before putting the last stitch, the anesthetist gives a positive pressure, and you can close it primarily. The carbon dioxide is one of the most diffusible gas, so it's just going to get absorbed in an hour or two.
Yeah, Dr. So Dr. Bakshi had a similar question. And if you want to add something, I mean, your personal experience which you have come across and you can pass on the message, difficulties and solution.
So one information I think everybody should, splenectomy is a surgery where the patients, again, in every surgery we need patients, spleen should not be injured at any point of time when you do a splenectomy. It's not like other surgery. That's the message always you keep in mind.
Thank you, Dr. Tamanas.